The slides move, yeah, great. Uh, so good afternoon to everyone. Happy to see you all. Yeah, after a short break, yeah, like we have 2 weeks once or 3 weeks once the lecture. Uh, so today we are going to focus on injuries of vertebra. So this topic is an interesting topic. So we try to compile the topic in such a way that you understand the concept, so you can do primary, that is first medical aid to your patient, yeah, and you can think about how to treat these patients. So when we talk about injuries of vertebra, yeah, so here are some statistics. For an example, in North America, yeah, so they say around 11,200 person injured, yeah, there's vertebra yearly. About for those 200 of them are killed on the place of incidents. Yeah. So statistic also shows that very common place for injury of this vertebra are the mobile segments of the vertebra. So if you take vertebra, yeah, so vertebra has, if you take vertebra, they are divided into what: cervical, thoracic, lumbar, and sacral and coccyx region. Yeah, so mobile segments, which area of the vertebra is very mobile? That is, your cervical region is very mobile, and your lumbar region is um, mobile. When compared to thoracic region, it is not mobile here because your chest, ribs, and the sternum here form the thoracic cage. So this segment of the vertebra is not mobile. Sacrum, you already know it is a fused bone attached to the pelvis. It is not mobile. And coccyx, once again, it is also a fused bone. Yeah. Sometimes patient can have a injury between sacrum and coccyx in this region, and in that case, there is a condition called as coccydynia. So we can discuss about this thing also as we go to the end of the lecture. So here, some statistics. International statistic that talks about, so 10 to 15 per million, yeah. Averagely we can see very common in an adult age group 18 to 35 because of their activeness. um, More male when compared to female. Very common is road traffic accidents. Yeah, so when compared with other causes like domestic and industrial, yeah, or sports, sometimes maybe a big role can be taken by self harm when people try to commit suicide. So these are all the incident rates. So here the rates like 10 to 15 per million. This is a very not stable figure. Yeah, this can increase a lot, depending upon country to country. So as we discussed before, so we told the mobile segments. Yeah, so cervical segment very commonly affected. Yeah, and dorsal lumbar region. Yeah, so we can see they are the most common region to be affected. So a little bit you should understand your anatomy. Spinal cord ends at the level of L1. Yeah, cauda is below N1. Yeah, so when there is mechanical injury, there can be early ischemia, cord damage, or necrosis can happen here. So everything depends. When you talk about injury in the vertebra, so it leads to different levels of damage to your spinal cord. So depending upon that, we'll have different types of clinical pictures. So here we can see we can see a lateral section of a lateral view of a vertebra. So here we divide the vertebra into three columns: anterior column, middle column, and posterior column. So what comes into the anterior column is anterior tooth of the vertebral body comes into this anterior column, which composed of the vertebral corresponding vertebral body, intervertebral disc. Yeah, anteriorly we have anterior longitudinal ligament. So this comes into the anterior column. Rest 1/3 of the vertebral body comes into the mid column with its posterior longitudinal ligament. The rest, all the component comes into the posterior column. That includes what happens in your transverse process, spinous process, your arch of the vertebra, your intervertebral, superior, inferior articulating surfaces or facets. Yes, so all these things with the ligaments that we have over here, we might have supraspinous ligament, interspinous ligament, there will be intertransverse ligament, ligamentum flavum. All this component comes under your posterior column. So after studying a little bit of anatomy of the bone, yeah, So let's talk about how this vertebra can get damaged. So mechanism of injury, mainly it will be indirect mechanism of trauma. So here we can see in this picture different variants of indirect mechanism of trauma that we can see over here. Yeah, so here patient maybe fall in such a way. Yeah, maybe he's an athlete. Maybe so when he's falling in this way, what happens? So he's flex. He's doing flexion movement. So here what happened? Compression fracture happened in the vertebra. So there is what happened? Flexion and compression. Yeah, so there is flexion and compression mechanism here. Here also the same mechanism. There is flexion and compression. We can see over here. So here, when patient, like for an example, a person try to dive, he doesn't know the depth of the river or whatever thing is. So when the patient dives, so he will have. So we can see over here in this picture. So we can see over here in this picture that patient has a flexion, compression, plus what happened? There is torsion also. Not only patient has a flexion, yeah, but there is also torsion, rotational type of movement and compression is happening. Next, we can see over here in the last scenario picture that we can see over here in this patient. Patient has what? Extension type of fracture. He's extending his cervical vertebra, and also there is a compression mechanism. So we can see over here. Yeah. So when patient comes to the hospital with injury of vertebra, yeah, so we trying to ask how the patient got the trauma, to know where this problem would have probably, how the patient got the trauma will give us an idea where the problem would have been localized, and it will make us to think what probable complications we can expect from this patient. So let's continue over here. Yeah. Um, so when patient has this type of compression types of fracture, yeah, so what is going to happen? So here we see a lateral view of the cervical vertebra. As here in this place, we can see a schematic diagram. In the schematic diagram, what are we seeing? So we can see vertebral body looking normal, and there is a compression happening here. That schematically it shows like a cone type or a wedge type of compression that is happening in the vertebra. So when patient has a flexion and a compressing force, patient will have what? Compression fracture of the vertebra. You see, you compare the vertebral height above. Suddenly what happens? The vertebral height decreases. After that, it is normal already. So here in this region, yeah, there is compression of this thing happens. So you will calculate the cervical vertebra from atlas axis. You 1, 2, 3, 4, 5. So you will automatically think maybe fifth or sixth cervical, depending upon where it is localized. Yeah? So you will concretely write which vertebra underwent the compression type of fracture. We have different classifications. Widely to group the fractures of vertebra, it is widely grouped into two main groups. So here we can think about fractures vertebra, is it a stable or unstable? So when a patient comes to hospital here, in your mind should run, this patient had a stable vertebral fracture or an unstable vertebral fracture. So what can come under stable vertebral fractures? So stable means it is a fracture. Stable vertebral fracture means it is a fracture of vertebra. So patient has a fracture of vertebra, but there is no displacement. There is no displacement. In alternatively, it is better to use the word there is no dislocation of the adjacent vertebra. So stable means fracture without any dislocation of the adjacent vertebra. So let's see what fractures can come under this table. So here the first criteria, so should make a note when there is a compression. Yeah, so here we use the word compression. So we can see in this picture when there is a compression until half of the height. So until half of the height of the vertebra, if it is compressed, the fractures are considered as stable fracture. Next, in the next picture that we can see over here, yeah, so vertebra has always an angle, yeah, so this anterior superior angle, this is anterior inferior angle. So whenever there is a fracture of an anterior superior angle of the vertebra, once again the prognosis is good. Why it is good? What happened? the fracture is going to be a stable type of fracture. So fracture, avulsion fracture, especially when patient will have extension mechanism, patient can have like this avulsion fracture of anterior superior angle. Next, we can see fracture of spinous process or transverse process. They does not involve spinous process or transverse process. They do not cause the stability of the vertebra. They do not participate in stabilization of the vertebra. Yeah? So when this structure get damaged, we will not have any displacement of the adjacent vertebra. So these three variants are considered as a stable variant of fracture. Moving to the next variant, so when we discuss about the other group, it is called unstable fracture. So unstable fracture means fracture with dislocation of the adjacent vertebra. So let's see which can be. So it is going to be a little bit clear. Yeah? So in the previous thing we discussed that height should be less if there is going to be compression, more if it is going to be greater than half of the height of the vertebra, for sure that we can see in the even the schematic picture over here, when there is height of the vertebra dropping more than half, the above lying vertebra is going to get dislocated. So this is one variant. Next variant, when there is a burst or a multi-fragmented fracture of the vertebral body that we can see in the picture that is being shown over here. Yeah. So in this case, there can be a unstable fracture, or when there is damage to posterior supporting complex. And just now we discussed, yeah, everything behind this structure is a posterior area. So when posterior supporting complex is damaged, it can lead towards spondylolisthesis. It can lead to a displacement of the above lying vertebra. So from our discussion so far, you would have understood one concept. Whenever there is a damage to the vertebra, the above lying vertebra is the one that is getting involved in dislocation. So far, any questions, doctor? So far, do you all understand everything? Any questions so far? Hello?
No, sir. No, sir.
So far clear, yeah, great. So we finished. So we just now we saw, yeah. So what happens? This vertebra is going to compress, the above lying vertebra will get dislocated. So when this process is happening, yeah, so one vertebra compressed, the above vertebra is getting dislocated. The posterior superior angle of this damaged vertebra, that is this angle that we see over here, yeah, this angle is like called as a wedge urban or a raw wedge. Yeah, why it is so? Because why it is a dangerous angle? Because this angle will go compress the spinal cord and cause what different degrees of neurological deficiency from that level of compression. So this thing you'll be seeing over here. So here there is a classification, Frankel's classification of cervical spine injury. Yeah. So grade A, complete paralysis. Yeah, that means grade B, sensory functions only below the injured level. Grade C, incomplete motor function below the injured level. D, fairly good motor function below the grade level. So E is normal. Yeah. So here, so it depends. So if, for an example, if patient is injured in the cervical vertebra, yeah, patient can become quadriplegic, if or hemiplegic, depending upon the type of injury the patient had. Yeah. So if it is going to be injury in the lumbar region, yeah, so patient below the hip, from the hip until both lower limb, he might have paralysis or paralysis. Yeah. So those symptoms can be present. Next thing, we have to analyze how we have to know the degree of compression. How to know the degree of compression? So here we can see. How to know degree of compression? It is classified into 4 degree. Degree 1, 2, 3, 4. For an example, in we used to study. I studied like this. So my 4 fingers is equal to height of a vertebral body. So we can see over here. Yeah. So height of a vertebral body. So if one finger crossed, yeah, one finger crossed. So it is first degree, 2 fingers, second degree, third finger. Yeah, third degree more than that is already 4th degree. Yeah. So in other ways to say, in a medical way to say, how is it? So here we can see when 1/4 of the height is lost, first degree, until half is second degree, until 3/4 height is lost, third degree. If it is going to be more than 3/4, it is 4th degree. So how to know the height of the vertebra? So you see in a lateral view of X-ray, suddenly there is loss of height of a vertebra. So what you will do, you measure on the X-ray how many centimeter is this height. Then you go above and go below the vertebra, measure this height, divide by 2, and you'll get an average height of the vertebra. Then you divide it into 4 fragments, then you know already how much degree it is compressed. So let's give an example. Yeah. So let's give an example. Imagine this height was 2 centimeter and this height was 2 centimeter. What will be the average height, doctors? What will be the average height of vertebra in this region? Hello. It's going to be what? Hello. Doctors.
2 centimeters.
2 centimeters.
Yeah, I already wrote everything. Yeah, so slow, yeah, you people. So it's going to be 2 centimeter. Let's see the patient when I measured this height was 0.75. Which degree of compression it is? If this height is 0.75, what degree? Doctors, tell me if it is going to be 0.75, which degree of compression? Hello? Doctors, I'm waiting for your response. If this height is 0.75 centimeter, which degree of compression?
Third degree.
Very good. It is third degree. Yeah. So it is 1 centimeter is until 1 centimeter is half, more than 1 centimeter is more than half. Yeah. But it is less than 1.5 centimeter. Yeah. So it is like height is only 7.5. Yeah. So it is patient has what? Third degree. Yeah. Understood, doctor. So any questions on this? Hello?
No, sir.
So you have to think about this thing. So tell me which degree is stable, which degree is unstable in this thing. We have 4 degrees. Which degree is going to be stable, which degree is going to be unstable?
I think first and second.
What do you think, doctor? Which degrees are stable and which degree is unstable? First and second degree?
Is stable. Then third and fourth will be unstable.
Okay, very good. Yeah. So first and the second degree is going to be stable, and third and the fourth degree is going to be what? Unstable. Understand, doctor? So simple already. Yeah? So here, that's all. So let's think about what clinical symptoms we can expect in this patient. So clinical symptoms can start with patient will have what? Localized pain. A patient has localized pain. His patient will point out, yeah, I have pain in say, neck region or lumbar region. Patient will point out the pain. So if it is going to affect the nerve root, it will be radiculating pain. Yeah, pain from the back radiating through the projection of the nerve. Yeah, to the lower limbs, right lower limb, left lower limb. So it depends. Radicular pain can be present in the region. There can be bruise. There can be loss of function. So you once again you can understand vertebra is located retroabdominally. So as the vertebra is located retroabdominally, because of bleeding, yeah. So you understand the first stage of from your last 2 lectures, yeah. First stage of fracture healing is what hematoma, yeah. So as vertebrae are retroabdominally located, because of the fracture, yeah, bleeding can trigger or stimulate what happened peritoneum. Patient can complain of a pain in the abdomen, but here pain arises. It is not because of acute abdominal syndrome like gastritis, maybe, yeah, or appendicitis, maybe, yeah, or any other acute abdominal condition. Yeah, here the pain is triggered because of compression of the vertebra. Yeah, so this is called as what pseudo abdominal syndrome. So we can see the general signs. Specifically, what we can see. Specifically, you will check the dermatomes, you will check the reflexes in the region. Yeah. So if it is not lost, it is good. If it is lost, yeah, so we can define and from which level of paresis or paralysis happened in the region. So if you take first degree and second degree of of compression of vertebra. Mostly what happened, there will be less clinical conditions, yeah, or neurological conditions, yeah. But if you are going to take third and fourth degree, yeah, there will be marked degree of paralysis and paralysis in that affected side. It will be present already, yeah. So here some schematic picture that gives about what happened, level of what happened, spinal injury, yeah, investigated from where, yeah. So it talks about which levels we can see and what can be affected. It is being shown in these two diagrams. So of course, before I told you, all these reflexes will be either absent or decreased in this patient. What else can be done? Yeah, so on examination of this patient, what happened? You'll palpate all the vertebra, starting from your spine, cervical vertebra to your sacrum. Yeah, so what you will do? You'll palpate spinous processes. Then with your two fingers, you palpate your transverse process. Look for pain. Yeah, or any discomfort that patient is showing. Yeah, then you can do what axial loading of the vertebra. Yeah, so in the cervical region, what happened? We can compress the head. We can press the head. Patient will complain of pain in the neck, or you can press the shoulders. Yeah, so patient can complain of pain in the lumbar region, or you can tap the patient's sole. Maybe patient will complain of pain in the lumbar region. Yes, so you might have different. So with this thing, what happened? We can try to once again focus where the problem happened. Yeah. So as a mandatory rule nowadays, what happens if patient is a victim of a road traffic accident or high energy trauma? Yes, so we always suspect there will be injury of cervical vertebra or head injury. Yeah? So in those cases, for sure, what happens when you're transporting the patient, we have to transport it with this following measure. Apart from that, in general, any injury to vertebra, how to do first aid. So it is explained over here in a simple words. Yeah. So first step, what we have to do, we have to do analgesics. We have to give analgesics to the patient. Yeah. For an example, 2 ml Baralgin intramuscularly can be given to the patient. Next, what happened? We have to fix the patient to a hard stretcher, hard sheet. Nowadays, what happened? We don't have metallic sheet. There will be plastic sheet. So you fix the patient to this hard sheet. Yeah. So cervical region, if you have collar brace, put cervical collar brace. If it is not available here, so we can see over here to put two wooden planks, fix the patient head so that this patient head is not going to the right or the left. If available collar brace, that will be the good thing. And as fast as possible, we have to transport the patient to the hospital. So this is what you will do. So it is a mandatory protocol. If patient is a victim of road traffic accident, though you don't find any clinics, you have to put patient in collar brace, and you have to transport the patient to the hospital. When moving the patient from the zone of incident to this metal sheet, also not one person, two person, maximum number of people, and limited movement that you should give to the patient head and neck or any other part of the injury, because any movement will trigger more further complications. So we discussed the clinics. I already told you the clinics. Yeah. So next, what do we do to the patient? So here comes the next step. So how to classify this patient? Treatment is based on the type of injury the patient had. So we already classified what is stable fractures and what is unstable fractures. So stable fractures are treated conservatively. And also what happened if patient had an unstable fracture to whom operation, a patient cannot take narcosis. In that case, maybe that patient will be treated conservatively. So rest all the patient that is unstable fracture completely treated operatively only. So how to treat the patient conservatively? So here, once again, we put the patient in the hard sheet. So in olden time, what happened? So it is done in such a way. What happened? Patient self traction. Yeah. So patient lies on a bed. It is elevated. Yeah. And what happened with his own body weight in traction? What happened? We can maintain patient in this position. Plus, what happened to maintain the lumbar region? Lumbar region, there is given a reclinator. Yeah. So booster is put in the lumbar region to maintain its lordosis. And patient bed is elevated. Yeah, he's lying in his own traction. This is one method. But what happened in modern? What happened? We can go for what happened if patient has stable fracture. We can go for using POP. We can make a corset. So in another techniques, what happened? We can go for hard collar braces that we can see over here. Yeah. So they pay the function of stabilizing the vertebra. So these are all some techniques in which what happened? We can treat conservatively this patient. Next, I told you there are some patients who has unstable fracture, but they can't go for surgery because of different reason. Yeah, so in those cases, what happen? We can go for skeletal traction, that is shown over here in this picture. Yeah, so if patient had a flexion mechanism of trauma during treatment, he'll be extended, or vice versa. If he had extended fracture, he'll be flexed already. Yeah, so patient will have a skeletal traction. So average term for consolidation of this fracture will go from 6 to 8 weeks time. So next thing that we have to think about is what happened. We have to rehabilitate the patient. So we start giving the patient medical exercise therapy. So exercise therapy is a mandatory thing. So it is divided into 3 groups. First group of exercise therapy is started immediately after the trauma. So patient, irrespective of where the patient had a trauma, yeah, so we do exercises away from the, for an example, here the patient has problem in the lumbar region. So exercise therapy will be done to the patient knee, ankle joint and foot. So when patient lying in the bed, he will do exercises. He will make movements in the ankle joint, yeah, interphalangeal joint, metatarsophalangeal joint. Yeah, so he will make exercise in this region. Same thing will go to your upper limb. This active exercise will start immediately. It will continue already. Yeah. Next group of exercise will start after 3 to 6 weeks time. In this group, so exercises will be focused more closer to the zone of fracture. That means we can go until the hip joint. Yeah. So what patient will move knee joint, hip joint. Yeah, while lying in the bed. Yeah. The last group of exercises it will be focused after 6 to 8 weeks time. Yeah, in the 6 to 8 week time. In this time, patient will be given permission to roll, and patient will try to lie on a. Now he is in supine position. He'll be trying to he'll be put in prone position. After that, what happened? He'll be given exercises to strengthen the back muscles. So imagine he'll be on prone position, and he will try to make like this movement. So where his leg will be here, yeah, his head is going to be here, yeah, his head. So he will do exercise therapies, yeah, extension exercise therapy, because here he had problem in the lumbar region, yeah. So he had problem in this region. So he'll be in prone position exercises like hyperextension exercises are given to this patient. When patient can do this pose without any problem, he or she is free to get discharged already. So here once again we can see braces. So when we put cursors of braces, so think about what happened. Back muscle will undergo atrophy. So prophylaxis to prevent back muscle atrophy is we give kinesotherapy. Yeah? We give exercise therapy for the back muscles. So this should be a mandatory thing. Next step, if patient had unstable fracture, he or she is indicated for surgery. So all unstable fractures should be treated surgically. So how to treat surgically? Yeah. So the surgery is called as what? Open repositioning. Yeah. And we fix the patient with what happened? Transpedicular spondylolisthesis. So here these are transpedicular screws. Yeah. With this apparatus. Yeah. So what we'll do? We'll improve. So it depends where the vertebra, which vertebra patient has problems. Yeah. So we put this transpedicular screws and this frame. Yeah. After that, we'll pull the string, and what happened? We tighten the screw, yeah, and it will get fixed already. Yeah, it will maintain. Yeah. So it is called spondylolisthesis. So because what happened? After this, what happened? The movement in that zone of the vertebra will be limited or completely absent until the time of consolidation of this fracture. So any questions, doctor? Any questions on this topic? Hello?
No.
No questions. Spinal injury. Yeah, so how to formulate the diagnosis? So a diagnosis you will write open or closed. Yeah. Next word you'll be writing about stable or unstable. So a stable fracture of which localization? Stable fracture of C1, C2, or stable fracture of what happened? Maybe L4 vertebra. Yeah. Next you will write which degree. First degree, second. So it is going to be stable means it is already clear. Right? It's going to be stage first degree or second degree only. Yeah. Followed by what complication? If it is present, some complication you will write. So another variant, closed unstable fracture of L3, yes, stage 3 with what happened? With paralysis, whatever thing. See, if patient has a neurological deficit, rehabilitation of this patient is going to be long lifetime, maybe what happened, patient will be what happened, the lifetime he'll be an invalid patient also. Understood, doctors? Hello? Understood, doctors? Hello?
Yes, sir.
So if no questions, yeah, group leaders. So everybody, you can leave a message in our chat. Yeah, you can put a plus so we know who is present. So group leaders, you will try to take screenshots and let me know in the group who is present and who is absent for today. So currently we have very less number of people. We have only 86 people. So everybody can leave a plus and you can quit already, doctors. Thank you. Thank you, doctors. So group leaders, later give me a list who is absent from your group. Okay, doctor, please call and check.
Dasvidaniya, sir.
Dasvidaniya, doctor.
Dasvidaniya, sir.
Dasvidaniya, doctor. So doctors, let's be fast. Hello, doctors. So let's be fast, okay? Please put ticks. Hello. So let's be fast, doctors. Please put plus, group leaders, take screenshot, and later update me in the group, doctor.